So I've got a lady that's been coming in, and she said, I don't know if you come across this. So she's got back pain, okay, but she's saying that she hasn't got a disc. They're saying that when they done the MRI, it's the vertebrae that's shifted. It's I don't know. So she's saying it's something called I don't know if I'm saying it's right, spondylolisthesis or something. So it's where one of the vertebrae slides forward instead of a disc. Have you come across that before?
Spondylosis.
What area of the spine, Nick?
I think, where did she say it was? I think it was about. I think she said it was. I can't remember if it was L4 or L3.
Right.
And the whole thing's gone, like, slid forward.
Right.
So obviously, it's only going to be a small amount, isn't it? But
yeah. So the body of the vertebra is tipped forward.
Yeah. So instead of like an actual disc sliding out, the vertebrae's moved itself.
Right.
Do I treat this the same as if I would treat a disc, or is there a different technique?
Basically, what you've got is I've got a pelvis here. Oh, you've got the vertebra there, even better.
Obviously, the same.
Yeah. Lovely. Stiffness bones there. So basically, what you've got is there's your normal lordosis, all the ones in red. That's your lumbar curves. So the body of the third lumbar vertebra. I've lost him. What we're doing?
No, it's caution. Sorry.
No. The body of the third lumbar vertebra is the most horizontal in the curve. So you've got the fifth tipping down, the fourth tipping less, the third horizontal, the second pointing up, and the first pointing up a little bit more. So that gives you this nice anterior curve. Now, if the body of a vertebra slips forwards, then there's no posterior support holding it back. So it's got to be the rotary brevis, the extensors, the multifidus muscles that are allowing that to happen. So basically, to tip forward, it's gone into flexion. So in other words, there's the transverse process. It's tipping forward. That's flexion, and we need to pull it back into extension. So the muscles at the back of the pedicles are going to be the ones that would pull that back in. Does that make sense? Now, cloacals can be very useful for that.
Are you looking at the position of the sacrum as well? Because obviously, the sacrum's tipped.
Yeah, but I was looking at the one particular one. Oh. Yeah, if the sacral angle isn't correct, and the sacral angle is dependent also on the femoral ligaments that we were talking with Chris earlier today. The femoral ligaments contribute a lot to the lordosis of the spine. So you see this triangulation that's going to go up to the femoral ligaments, the ischial tuberosity, and up to D12. So anything in that triangle needs to be stable. So if the femoral ligaments are not pulling properly, you'll lose lordosis. And if it's the third, you're going to lose it more at the third than any other. And the fact that it shows an MRI and it's slightly forward, it's significant, but it's not really what's causing the pain. So I'd want to know that I've got the sacrum back in position, the sacral angle is right. There's various ways. I'll do that more when we're here.
Because there was a model, wasn't there, that showed when the sacrum's tipped forward, the vertebra starts to drop off the top of the shelf of the sacrum.
I'll dig it out for when you come. It's a model that shows spondyloilio.
That's what he's trying to say.
That's the word.
Yeah.
And basically, right. Let me recap. Help me out.
The pedicles break away from the
sacral angles tip too far forward.
That's right.
L5 and L4 start to slip off.
See, when they look at the sacral angle, they won't say your sacral angle is too acute or too less, because that's selective to the person. But what they're finding is one vertebra tipping forward. Now, in spondyloilio, I can't say the word myself this morning, but basically what can happen is that the body of the vertebra, and especially the fifth, will start to tip more anterior, and it starts to tear away from the pedicles. And you get this on people who are quite heavy with a pendulous abdomen, can happen, that the fifth lumbar starts to tip forward and separates from the pedicles. And I had a guy come to me, he was about 5'6" and weighed 25 stone most of his life. And I managed that for many, 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 many years. He's had both hips done, both knees done, but the spondyloileoitis is under management. So can you see that to maintain that, you've got to have the right lordosis, which is dependent on the triangulation of the femoral ligaments, the position of the sacrum, the sacrotuberous ligaments, and then that and the 12th rib. If you stabilize all of that, then that vertebra should weight bear properly and move properly without problems. Do you get that?
Yeah. Yeah.
And
That's
again,
brilliant.
if I had a particular one, say it was the third lumbar that was therapy localizing, I'd want to work locally around the multifidus muscles, up the gutter, up the bladder channel, but I'd also go to the ischial tuberosity and just come on the inside of the ischial tuberosity where you're picking up the cloacals. Now, when you pick up the cloacals, this is where we need to develop our sensitivities, because it'll therapy localize, but you want the sensitivity that you're making a change. So say I'm in the pedicle of the third lumbar vertebra, and I'm sending a signal from the ischial tuberosity. I firstly want to make a connection. So the connection is going to feel like that as I load the ischial tuberosity, I'll feel a difference at the finger. Now, the difference is only subtle. So you've got to really switch off. These have got to be really listening fingers. So I'm pressing on the ischial tuberosity. I go, I've got a connection. Now, once I've got a connection, I then press this way or that way or this way or that way. So in other words, a little bit of omnidirectional movement with the thumb until it gives me the relaxation that I want. Then it's specific. So firstly, you make a connection. You've got a connection. You go, right, it's filled up. Then I go, does that alter it? Does that alter it? Does that alter it? And what you find is one of the positions will alter the vertebra more powerfully than anything locally or manual, actually. The ischial tuberosity really drives, especially the 5 lumbars, back into position. And that can bring it back into its integrity. Now, once it's back into its integrity, again, can you pass that tensegrity model there with just all the load of, and the 5 vertebrae next to it? Yeah, those and those, yeah. Yeah. Thanks, Paul. So what you've got here is 5 lumbar vertebrae, and what they're showing on this particular model, that you can see when we come, is normal disc. And then if I took these apart and part of them, it shows the nucleus doing various different things. It won't come apart. Now, what you've got is morphic changes taking place between the first lumbar vertebra and the 5th. So it's showing aging of the spine. Yeah. Yeah. And see down here, you've got morphic changes to this vertebra body in between 4 and 5. And what it looks like is you've got thinning discs. But what's really happening is the body of the vertebra is going more concave, and so the discs inside there. So it looks like it's thinning disc, but it's morphic changes approximating the 2 bodies, but the discs inside doesn't have to be herniated, it doesn't have to be damaged. So this is a sign of age. They just say, well, you've got arthritis. Also, what's happening is the morphic changes where the neural canal is coming out are starting to get nipped, and that's called stenosis. If that gets too bad, that's going to give you pain. That's called stenosis. So all of these things are happening as we age, but mechanically they don't have to be a problem if the lordosis of the spine is maintained in its tensegrity. So this model here basically represents those 5 lumbars, and there's your lordosis. So if one of those is allowed to pull slightly forward, then it's the tensegrity of the whole that's compromised. Does that make sense?
Yeah.
So
yeah.
As we change the pulls from the femur head, from the ischial tuberosity up through the coacals, and increase the lordosis of that, you might not change the position, but you'll certainly switch off the aberrant signals. Because that much out of position shouldn't be causing that much of a problem.
Yeah.
Does that make sense?
Yeah, thank you.
Okay.
I think Paula was going to ask something where you look like you were moving forward.
Paula.
Oh yeah, sorry, I forgot. I missed what you said about a frozen shoulder because my daughters had just come in from rugby.
All right, Don. I'm going to send
And
you.
I do have a case study with the frozen shoulder.
Right. All I was saying, Paula, is tomorrow I'm going to send you this doc. I might put it in the group this afternoon, then you can read it. There's a paper being written in the Lancet by an orthopedic surgeon in America, and she's discussing how perimenopausal and menopausal women lose estrogen, and when they do, it can cause frozen shoulders. So just to make you aware of people who've got coming to you of their age, that you can still help it, but if it's taken longer, sometimes it can be because the body's adjusting to the estrogen depletion.
Yeah.
That one. Yeah, down. Well, I'm going to send you it's a really interesting article. Yeah.
Yeah.
You're welcome, Don.
Yeah.
Right, I think we're going to go.
Yeah.
Like you have an early one. We'll see you 3 weeks' time.
Yeah. So again, we can cover all these things in detail. Any questions you've got, we can look at the models, learn the technique. Basically, just understand that pressure changes nociception, nuisance, interference to the brain. So pressure helps anything. Think about the small joints, no matter how small, treat them all as joints. Work around the neck and shoulders. We look at some of those inhibitory points. And basically what you're doing is palpating to make sure that the tissue between the ribs moves. And again, what was nice there shown on Paul was the rhomboids would have not give us a weakness until I inhibited the opposite one. Shows that that one showed that. The anterior serratus wouldn't have showed us if we didn't do the lengthening test on it. The subclavius would therapy localize, it didn't in that case. So it's looking at those different ways of making the thing show you what's going to be causing the problem, looking at the range that it's going through and saying, okay, if it's that, it can't be if it goes beyond there, it can't be the glenohumeral joint. Now it's got the scapulohumeral. What goes beyond there is the clavicle starts to twist, so now it can be the subclavius. Once it's got beyond that, it can't be that. Looking at the different muscles that triangulate to the shoulder, and looking at the cartwheel and thinking, okay, where's the tension? Is it along the supraspinatus? Is it coming from the plexus? Is it coming from the neck? And that's why all of these parts need to fit together. And the mobility tests are really what gives you that sense that once everything's gliding and moving properly, it's not painful anymore. And that's the biggest thing I've found over the years. If something moves through its normal range of motion, it doesn't hurt. It's only when it's restricted that it hurts, because the wrong messages are coming at the wrong time and saying, this hurts. And that's where pressure, muscles give you the three-dimensionality, ligaments give you the proprioceptive feedback in, get rid of the nuisance, joint goes to its neural pathway, restores its balance. That's basically the concept. If you keep it as simple as that, then you've got inroads to correcting anything.